Okay, great. Thank you everyone for joining. And we're delighted to have this session. And in conjunction with the celebrating 35th year anniversary of the Institute for Health at RBHS at Rutgers University. My name is Xingqi Dong. I direct the Institute for Health now. My background is a geriatric physician by training and a population health epidemiologist. And we're delighted to have a number of distinguished speakers with us today. But before we start getting to introduce our speakers, I'd love to have our Chancellor Strom to be able to say a few words about RBHS and about his background, as well as the Institute for Health. Dr. Strom is the inaugural Chancellor for the Rutgers Biomedical and Health Sciences, as well as the Executive Vice President for Health Affairs at Rutgers. Trained as a clinical epidemiologist and pivotal force in the field of pharmacoepidemiology, and who needs no introduction. So Brian, if I can turn the mic to you to do if you can share a few words with us.
Sure. Thank you, Xingqi. Pleasure to be here, everybody. Welcome to the Institute for Health, Healthcare Policy, and Aging Research, and thank you for joining us. My name again is Brian Strom. I'm the Chancellor of Rutgers Biomedical and Health Sciences. As Xingqi alluded to, my background, I'm a general internist. I'm also an epidemiologist and a clinical pharmacologist, and built my academic career in the overlap of the three, which is really has become named as the field of pharmacoepidemiology. RBHS, or Rutgers Biomedical and Health Sciences, is the healthcare education, research, and clinical division of Rutgers University, and was established in July of 2013 as part of the 2012 New Jersey Medical and Health Sciences Education Restructuring Act. It comprises most of the units of the former University of Medicine and Dentistry of New Jersey and several existing Rutgers units with health-related missions from before that, and the Institute for Health, Healthcare Policy and Aging is one of those. The integration of these units, which now includes 8 schools, about 250 centers and institutes, but 8 that are chancellor level institutes, like the Institute for Health, Healthcare Policy and Aging, and a very large behavioral healthcare network, has resulted in a single division of Rutgers that provides new models for clinical care and community service, future-focused education of the next generation of healthcare providers, and utilizing a team approach to care, and conducting groundbreaking science, public health, and clinical research. We are approximately a $2 billion enterprise, not including any hospitals. And so it's a very large enterprise with I don't know, 10,000 people, perhaps. And again, we really represent the key to providing healthcare, educating in healthcare throughout the state of New Jersey. Since its 1985 founding by Dr. David Mechanic, who you'll hear from, the Institute for Health, Healthcare Policy and Aging has become nationally renowned for meaningful and impactful work in areas of health equity, healthy aging, behavioral health, pharmacoepidemiology, health services, and health policy research. And again, as I was teasing David before this, I was from the University of Pennsylvania for most of my academic career, and I certainly knew about the Institute long before people referred to it as the Mechanic Institute, and really an extremely well-known organization and really dominating the field. The Institute's a hub for multidisciplinary and translational research, focusing on improving population health, and fosters rigorous theory-based research and innovative training, and supports collaborative opportunities for investigators across New Jersey and beyond. As part of the Rutgers Big Idea program, the Institute is launching a Center for Healthy Aging, which will pursue cutting-edge research into evidence-based practice methods focused on older adults. The center's work will ensure that the most vulnerable population has access to the best clinical care and services available in New Jersey and the nation. It will also serve as a resource hub for older adults, their families, clinicians, researchers, and community partners. Toward that end, it's really my pleasure to introduce the IFH to those of you who don't know it, to hear about this exciting development and plan in terms of aging, and with that, to turn it back to Xingqi, back to Dr. Dong, in order to continue the program. Thank you, Xingqi, and welcome everybody to this exciting event.
Thank you very much, Brian. Thank you very much. And for those of you who already heard a bit about the Institute, it's a very special place. And And over the last few years, we have grown substantially, and with the support of our VHS, and we currently have about 150 plus members from 30 different schools and units. And there were really the interconnectedness between theory-based research and applied research really beats, and making sure that we not only study the scientific questions, but making sure that they're applied. And I think the panel today will certainly illustrate many of the work that people have had connected with the Institute over the previous years. Instead of me talking much longer, I'd love to have David introduce our speakers. So David, who is the founding director of the Institute, and if you could be so kind to introduce our speakers today, that would be wonderful. So David, go ahead, if you can turn the camera on, and I'll put myself on mute.
Okay. I'm delighted to be here, and I'm delighted that Cinchi has been building the Aging and Health program to a larger extent than it was when we first developed the Institute. I'm delighted to be with this fantastic panel, all who have been long-term friends of the Institute. I came to Rutgers from Wisconsin in 1979, I ran a small interdisciplinary institute there. And Paul Cleary was one of our graduate students and did his PhD with me. And when I came to Rutgers in 1979, I was delighted to have Paul come as well as an assistant professor. And he and I collaborated in building our first research program prior to the intended development of an institute at some future time at Rutgers. I got diverted to become Dean of Arts and Sciences, and Paul was great in keeping our research program going over those years when I was Dean. And that research program became one of the research programs when we began the Institute. The other major preceding event was that when I came in '79, Alan Horowitz, a professor of sociology, and I applied for an NIMH training grant and received it, and it began in 1980. And the training grant was a very, very successful training grant covering health broadly construed, including aging. And over the years, we've had many wonderful postdoctoral students and even some predoctoral students. And at some points, we had as many as 10 postdoctorals at the same time. And it became a core training function of the Institute when it began. Paul then had gone on to Harvard, where he had a very distinguished career as a researcher and professor, and then on to Yale for 10 years as the dean of the School of Public Health. Paul has made a fantastic range of contributions in terms of healthcare measurement, in terms of HIV, and many, many other areas. And I'm delighted that he's back here at Rutgers again, and has been a very important part of the earlier development of the pre-Institute, and then the Institute visiting us very commonly. Susan Reinhardt is also an old friend. Susan was an outstanding nurse, very active in New Jersey, who came and also did a PhD in sociology, and I was her mentor during that period. She then, following her PhD, went on to develop an impressive program of improved long-term care in the state of New Jersey, working as a deputy commissioner of health. And then following that, she returned to the Institute when we established the Center for State Health Policy as the co-director of the Center for State Health Policy, doing a great range of work on nursing and on long-term care and aging policy. And Susan's a fantastic person and has now gone on, as you will know, I think, to Washington, where she has, in recent years, been the senior vice president at AARP, working on nursing and also working on long-term care and other health policy issues. Vince, I've known since 1980. I first got to know Vince when I was on the advisory committee for the National Hospice Study, which he was the research director of. And I got to know him well in the subsequent years. Over time, Vince has had a very, very impressive career. He's one of the most distinguished and productive researchers on aging, having developed lots of work in different aspects of aging, including nursing homes and long-term care policy and many, many other issues. So it's wonderful to have Vince here again. Vince, too, while he was never an official member of the Institute as such, he came frequently to talk to our students and faculty and played a major role in that regard. People had asked that I speak a little bit about the early development of the Institute, which I indicated first started as sort of a small research and teaching program in 1979 and was formally established as a research institute at Rutgers in 1985. The additional core of the program was the funding through the National Institute of Mental Health training program, which then went on very successfully for the next 35 years with very ample funding from the NIMH. In that regard, Alan Horowitz from the very beginning was a very important part of that program. He was the co-director and also a very important part of the Institute. We've also had, we went on then to make some strategic appointments, which were very important in developing the Institute. And two of those were very closely related to the effort to build an aging program. First, we recruited Howard Leventhal, who we knew from Wisconsin. He was the chairman of the psychology department and been in our program in Wisconsin. And Howard and his wife, Elaine, who was a geriatrician and became a professor at the medical school, came to build an aging program. And they had a merit award, one of these 10-year merit awards from NIH to build that program, in which they followed comprehensively a large population of older people in New Jersey, looking at the different aspects of their health and welfare and development. Howard and Lane were here for many years until they retired. Howard also built a very, very strong health psychology program, which was internationally recognized and known and was very, very important. I might say that as part of that NIMH program, we had a superb medical history program directed by one of our people who were involved in the beginning with us, Professor Gerald Grob, who was a magnificent historian who made great contributions to the study of mental health, but also later to other conditions, other aspects of medicine. Jerry was one of the first historians elected to the Institute of Medicine, now the National Academy of Medicine. We've had a large number of people. I can't mention everyone, obviously. And the other major person we recruited during this period was Professor Stephen Crystal, who is still a very, very busy, active, successful researcher at the Institute. Stephen had done rather impressive work on aging policy in healthcare, wrote a marvelous book early in his career, and then came to Rutgers, in which he developed first work on nursing home care and care in other residential facilities, and then developed a very extensive AIDS program over many years and made many contributions to aging in health and to HIV study. In addition, we had other aging scholars who I can't say very much about now because of lack of time, but we had people like Ellen Idler, who's now a professor at Emory University, and Debbie Carr, who's chair of sociology at Boston University, who were major aging scholars who contributed over the years to contribute a great deal to the aging study, aging development studies. And as I said, we have had many, many outstanding people, and the Institute was an activity which involved lots of people from lots of different fields, and its success was really a product of all of these people who very, very successfully worked together over time across many disciplines. But I don't want to take any more time for our wonderful panel, so let me stop now, and I really look forward to hearing from this wonderful three friends of the Institute.
Thank you very much, David. That was great. And we're delighted to have many of the folks that David mentioned with us today, especially Steve and Howard Leventhal and as well. So if I can turn to our distinguished speakers, perhaps Susan first, to sort of, since this panel is really talking about aging in the era of COVID, perhaps just to frame us a bit, what are the major issues facing AARP members and older adults in the midst of COVID, and what kind of initiatives AARP prioritizing during the pandemic?
Thank you, Dr. Dong, and thank you for that warm introduction, David, my mentor, my colleague and friend, and also Brian, Dr. Strom. Thank you so much. I'm really so thrilled to be invited to this. I kind of grew up in this institute, as you heard, getting my doctorate here, and being exposed to these fantastic scholars from so many different disciplines really broadens your mind so much that it affected my entire career. So again, I'm here with deep gratitude. Thank you. So to answer your question, Dr. Dong, I was thinking about how to respond to that, about what issues are facing AARP members and of course older adults. And I thought I better start saying something for context about who are these members. So there are 38 million members, and half of them are in their 50s and 60s, and half of them are 70 and older. So it's a very broad age range, and therefore lots of different lifelong kinds of issues that people bring. Also, we used to be known as the American Association of Retired Persons, but now we're just AARP because more than a third actually work. In fact, most of them are working full time. I'm saying half of them in their 50s and 60s. So it's not surprising that would be the case. And one thing dear to me to mention is that 4 out of 10 are family caregivers, either of their parents or their spouses, but also for adult children, which was part of my dissertation with David, adult children with mental health concerns or physical disabilities. So it's quite a mix of people. So given this diversity over this past year with COVID, you can imagine just what all kinds of multifaceted, sometimes it just feels palpable when you're talking to members or you hear from people of their concerns. Our oldest members are panicked, frankly. They know they're at the highest risk, especially those who are in nursing homes or fear that they're going to be in nursing homes. They're even worried about getting long-term services at home because they know that they are such risk. Of course, our multicultural members know that they are at especially high risk no matter where they live. That has become increasingly evident. Our caregivers, as I mentioned, are really frantic about making decisions and nursing home placement or finding services. And even if they could get someone into the home, what does that mean? So many questions they have about, should I do that? How do I prevent getting sick? And those who are working share the same concerns as younger people who are working. Am I going to lose my job? Have long-term unemployment? About 55, the labor force participation of people 55 and older is down by 2 million compared to the pre-pandemic levels. That's worse than the Great Depression of 2008. So it's still very serious, losing jobs. There's pandemic fatigue, as we're all experiencing. There's social isolation that is really very real for all of us that are confined, but particularly for older people that are confined in nursing homes or in their own homes. And they're desperate to see their grandchildren and family. 70% of our members are grandparents. So they care a lot about younger people, I can tell you that. And they're just so anxious. That brings us, of course, to what we were talking about before this started, while we were waiting to get started, and that's vaccines. There's this incredible sense of urgency that we need to get a vaccine. I got to get a vaccine. How do I get a vaccine? I have to get up at 3 o'clock in the morning and go on this list and that list. And that's for people that know how to do that on the internet. So that is, and then on the other side, there are people who are afraid of a vaccine hesitancy. And should I do this? And that's particularly true of staff in nursing homes. So we do find that older people, and certainly our members, are deluged with information. They're nervous, they want to read, they want to know what CDC is saying, but blah, blah, blah. They really have been coming more and more to our website. This is one of the solutions, I guess, for us to try to distill it, translate it, package it in ways that are understandable, working, of course, with only evidence-based information, of course, sharing stories and what have you. But I also wanted to share that, I'm telling you all the doom and gloom, but there is a tremendous interest in being fit and having fun in a lockdown world. And I was really surprised to hear this. 4.5 million people have been coming to our websites to be engaged in things like physical exercise videos and what to eat, what to cook, how to get better sleep. And even things like musical programs that we've been offering. So they want to have fun. And many of them are also volunteers. So we have started a program, it's called Friendly Voice Virtual Volunteers. These are people who are willing to call people who want to be called, who are socially isolated. And so far, and this is a couple of months now, it's 20,000 calls so far. So those are just some of them. In terms of what we're prioritizing during this pandemic, we call ourselves, and I kind of like it, it's very ARP, but a wise friend, giving information and what have you, and a fierce defender, advocacy, right? And I'm kind of both, leading the Public Policy Institute, more the fierce defender advocacy, giving the information that can be used. So our first is nursing homes. This has been going on almost a year, since March of last year, a nursing home campaign. And it started with just trying to understand what was going on. You could see people were dying. Now, 40% of people who have died of COVID have been in nursing homes on average, varies across the states. And this is global also. And so we started with transparency. What is happening? Members would be calling, we don't know. I don't know how to find out what's going on. I can't go visit. I don't know what's happening to them. So part of it was transparency. And of course, that means getting data. Now, all the people on this panel, and presumably most of you on the phone here or listening in on Zoom, care about data. We want data. We want to use data. I, in particular, am biased towards using it to make something happen, some change. So we are using what is now Better Data, the Centers for Medicare and Medicaid Services. I know Vince is very interested in this as well. And I created what we call the ARP Nursing Home Dashboard. So this isn't our data. This is federal data. But what we did was try to distill it and focus it. So we are focusing on just a few of the data points, like resident cases, resident deaths, staff cases, staff deaths, staff shortages, and the extent to which a state has the facilities have at least a 1-week supply of personal protective equipment. So that's just a few of the many data points, but we have it for every state. We do this every month. We track it over time, and then we really push it out. And it's really meant to help states and the nation stay focused. This is still a really big problem and what we need to do about it. So leading towards more solutions. We're doing this, by the way, with my colleagues, Bob Applebaum, some of you might know him, at Scripps Gerontology at Miami University in Ohio. And so that's what we're really trying to do, more long-term solutions. I should mention, we're also going to get into multicultural data. That was just published by JAMA just this week, I think, about how bad it is, the differences in nursing homes that have a high percentage of Blacks and Hispanics. 3 times more likely to have these deaths occurring, but we want to know more about why. So we are embarking again with our colleagues and looking at how to explore this data and really, again, working with external experts too. What do we do about that? Do you want me to stop? You came back on.
No, go ahead, finish your thought, please.
Okay. Anyway, we are also, of course, trying to look at home and community-based services. That's always been a passion. I'm a visiting nurse by background. What can we do about that? And our goal is really transforming long-term care. It's going to take years, but we have really, ARP is committed to this, has made this like a top priority. We are going to try to do something about this. I started something called the LTSS, Long-Term Services and Supports Choices Program, trying to find evidence-based options that we can scale up. What are some new ideas? And how does this all lead to larger transformation? Things like housing, services, workforce, and connections to the community. A lot of this is stemming from work that I've done, created a long-term services and support state scorecard, and Vince has been on the advisory committee for a decade. Thank you, Vince. And so it's all about data. It's like, what can we find out and how do we get it into the hands of people that can use it with discussions, with ideas, and coming to solutions. Family caregiving is a big priority, particularly in COVID, people coming home or not even going anywhere because they're sick. And we are asking them to do things that typically only nurses did, but we don't give them much instruction. So I just started a whole video series. One of them is like, how do you do transfusions in the home for kidney problems? So we are also, I don't know how much more time. I just want to say one other thing about vaccines. This is really, really big. We just had a big discussion on it. We now have on the website, if people are interested, by state, this is updated constantly. What is your state's policies around this? How do you register for appointments? Who's eligible? And we're advocating for equitable distribution. And you got to have phones. People can't just use digital. So lots more we're doing, but thank you for that opportunity.
Thank you very much, Susan. That was wonderful. Vince, if I can turn to you, international renowned health services researcher, and what are some of the research questions and projects you're exploring in relation to older adults with COVID? And I guess related to that, what are some of the salient issues affecting older so that you don't think that we're not paying as much attention to currently?
Great, thank you very much, Tom. This has actually been, I imagined that sooner or later I would begin to retire, but over the last year, it's been, I've been working harder than I've worked in a long time. So last March, when the first resident died in a Washington State nursing home, it was followed by horror stories in New York, New Jersey, and so many other places, particularly in the Northeast, and no one knew what was happening. The nursing home residents were literally stacked up like kindling wood in New York, outside of New York nursing homes, and it was really kind of thought of as a disaster. So my NIA project officer and I talked, and we wanted to get data. We needed to have data right away, and so we needed to have it also in a very rapid turnover, as Susan was reflecting. And so this was actually particularly in the spring before other sources of data became available. So we reached out to a company that we'd worked with before called Genesis Healthcare, which is one of the largest nursing home companies in the country. And we had done work with them before on various trials of various interventions. And so we thought if there would be a way where we could take their data and rapidly look at it and analyze it, and we could then collaborate and work together so that we could put their analytic resource, our analytic resources of all my smart young postdocs and graduate students and junior faculty at their disposal of the Genesis people, learn how their data made sense or didn't make sense, and then advise them on how to grapple with operational problems. And so we did that, and since basically April 1st, we've been downloading their data every single night, their entire electronic medical record on hundreds of thousands of residents, and in fact, also many, many staff members. And as part of that, so we've been able to work with them to make sure that our data were that the data actually made sense, that were valid, and that it worked with their IT people. And so literally we've met every Friday for an hour, plus my group meets once a week in addition to that. And we've struggled with what is the right question, what information do they need to make the better decisions. So we've done things, amazing analyses, looking at things like what are the determinants, not just of what is an outbreak in the building, but who and what kind of, which of the patients in the building die, not in the building die. And then we've also looked at that particularly as point of care testing emerged. So we actually began saying, so what is the relative value of the point of care testing relative to the PCR testing, which is almost always run by the state departments or laboratories because of its costs. But those results are almost always too late for what's going on. I mean, they're 3, 4, 5, 7 days late from a PCR test comes in, and you don't know what to do if you're doing that. So as part of this process, our results have been helpful to them in shaping their policy about cohorting, when to, how frequently to test, and then also how to organize which staff get tested or which staff don't get tested in which buildings, and particularly for patients, whether some patients who are negative should be put with patients who are positive, and under what circumstances that should be done. And so through that, we've also published a bunch of different papers, because the goal was, if what we can actually help you with also makes sense as a publication, as something that the rest of the world would care about, we've been publishing those pieces of information. And so now we're working with them on vaccination hesitancy, and vaccination rates. So we're looking at what the effect of the vaccination results are. And it's been, in many respects, the most gratifying experience I've had for years. And since the people on my team who are working on this are all junior faculty or fellows or graduate students, I remember talking with David early on, because he was an advisor to me, not just for the National Hospice Study, in the early 1980s, is that formative careers you have in your early career, formative experiences you have in your early career are really defining as to what you think is important, and it shapes the rest of your career of evolution. And the team and I just talked about that this morning, and they're all so feeling blessed that they've had this experience of active applied research with in a real-time basis. It was really exciting for them. And to actually go a little bit step further is that the data we had what got the attention of CDC. And so for the Centers for Disease Control and Prevention, they were actually extremely worried that they were going to be rolling out mass vaccinations in virtually no time at all. In a month and a half, they had planned to vaccinate 1.5 million people in residential care settings. None of those people looked like anybody who had been in any of the randomized trials that had been done. And so we worked with them to put together a relationship, working with the National Institute on Aging, which is our sort of sponsor. They had an interagency agreement that they put together. And we then identified, basically at every night, we run the data and see what new adverse events were reported, both in the new diagnoses as well as in the EMR from the orders and from the nurses' notes that might be present, and the change of condition records that were there. And so we were able to identify the fact that there was no differential short-term mortality rate, even though there was a big time when the UK and the Norwegians were saying, oh, but all these old people are dying. Isn't that terrible? But we said there were actually as many people dying in the buildings that had yet to be vaccinated. So it became a really important topic right then for CDC to actually be able to report about this. It was a very important sort of and topical idea that, again, the people from Genesis were completely engaged with us in this entire process. So we've been doing lots of other stuff with this kind of data as it's come in. But Don, you also asked sort of what else is no one thinking about? I mean, people are beginning to think about, but no one's quite figured out how to do it. Is it basically we've had this horrible experiment that we've all been engaged in, where as a society, we basically said, we're going to place the safety and health status of all of these 1.5 or 3 million people in long-term residential care, and many older people as well. Their safety is a priority over their quote unquote quality of social engagement and social life. In most nursing homes in America and in many assisted living facilities, people are eating alone where they used to eat with friends. People are eating, and the only people they see are staff who are dressed as if they were on the moon, in space gear. And so this notion of disorientation is primary in their lives, in their experience for almost a year. No one's yet put together the data to see what's the, what's the excess mortality that might be associated not with the COVID, but with the other parts of lockdown, the other sequelae of lockdown. This is a critically important thing that we're now beginning to look at, how you look at it, how you think about it, how you build in a model for what are the outcomes that one would look at to see whether or not those have changed. Some of the data are present, but with the existence of an electronic record, you can actually begin to look at the increasing incidence of words like depression or anxiety or loneliness or lackadaisical or apathy. Those are that's the nature of the language that's in the nurse's notes in the electronic records. And we're beginning to tap that stuff now to give us some signal as to what is going on. In nursing homes across the country now, many states are beginning to think about, now that we've vaccinated people, and the vaccination rates for residents, not staff, but for residents is well over 80%, 80, 85%, higher actually than seasonal influenza vaccine, which is really important. But those people are now saying, so when can I see my family? When can I see my granddaughter, my great-granddaughter? When can I see those people? And so the facilities are trying to figure out, in concert with the state and the CDC, what's the right approach to having a revisitation schedule for, under what circumstances and what conditions can people do that kind of work, can have those kinds of visits? Does it have to be behind plastic? Does it have to be behind this? Do the family members have to have already been vaccinated? And sort of walking through those guidelines is a really key issue that's now being grappled with. And we're trying to think about standing up a randomized trial of an app that would make it possible for the family members who schedule visits to actually have information about, have they been vaccinated, have they been tested, et cetera. And then that would help the facility schedule the meetings in accordance with the right kind of conditions, et cetera. We're still working on that, but that's the nature of the really applied work that is so crucial in this day and age, given this crisis that's here. So I'll stop there and I'm looking forward to Paul.
Thank you very much, Vince. That was great. Paul, if I can turn to you, Dr. Cleary is not only being a friend of the Institute, is being a generous supporter of the Institute as well for many years. Paul, from your perspective, how has the pandemic impacted the delivery of care to older adults? And what are being done to enhance quality and address the gap in care during the COVID-19? Paul, we can't hear you. Let's see if you can.
Can you hear me now?
Yes, perfect. Go ahead, please.
Great. Like many things in the pandemic, we're still learning what the impact is. But one of the huge impacts is obvious to everyone. There's been a dramatic decrease in face-to-face meetings, in-person meetings, and then an emergence of telehealth meetings. And I'm just going to see if it works to try and share a slide. Can you see that slide?
No, I cannot see the slide.
Okay, well, I'll just describe it then. As I said, there's been many characterizations, but the number of in-person visits has fallen dramatically. And although there's been telehealth visits for a while, the increase virtually across the board has been dramatic, and not just for outpatient visits, but inpatient visits. But if you look at the graphs, unfortunately, I can't share them. The net number of in-person plus telehealth visits has been substantially lower than the number of visits prior to the pandemic. And we don't really know what the impact of this is. It's a very interesting natural experiment. A lot of things that we would have done a year ago are not being done, been substitutions of certain types of services. So a lot of people now are doing a lot of analysis to try and understand whether it was harmful not to have those visits, whether there's some beneficial effects. A lot of my colleagues are actually saying some of their telehealth visits are more effective and they reach more people than in-person visits. I'm sure everyone on this call or everyone listening has had these kinds of experiences. Until about, I'd say there was a report from the Commonwealth Fund that came out in May, and there had been a little bit of a rebound, but still the net number of services was about 30% lower than it was pre-pandemic. In October, another study came out that the Commonwealth Fund has been working with a group called Prescia. They have about 50,000 providers throughout the country, and they're monitoring the types of visits and the number of visits. And those are almost back to baseline now. So there's been a dramatic decrease. There's been about a 8-month, 1-year period where the way in which healthcare has been provided has changed dramatically. It's starting to get back to normal, except that, of course, we're doing many more interactions by by telehealth. There have been some analyses of which types of visits declined the most. Surgical procedures, pediatrics, interestingly enough, and so on have declined the most, and some other ones have declined less so. And so there's a lot of ongoing work by our group and other groups to try and understand what the net impact of those was. Now, we're focusing on aging, and I was very interested in this because my intuition was that the impact would be more dramatic on older patients, I guess of which I'm one of them. Older individuals are less attuned to using the internet, patient portals, and so on. So my expectation was that older individuals would have larger deficits in care and would be slower to rebound. Interestingly enough, I have the Commonwealth Fund has published these data, and I was going to show you some graphs by age, but interestingly enough, the group that had a moderate decline and has shown the sharpest rebound, if you will, back to almost baseline has been those over 75, and the next group is 65 to 75. So my intuition is often the case, we're totally wrong. Older individuals seem to be getting care, whether by in-person or televisits, and when care rebounded, it rebounded most for older patients. We just did another study when I wanted to test another one of my ideas, is that even if they are having more visits, older individuals would have more difficulties, would have problems with the technology and so on. We just, one of the surveys I've been involved in the development of is the Consumer Assessment of Healthcare Providers and Systems, or the CAHPS survey, which is done all over the country, both for ambulatory care and inpatient care. And we have been revising those surveys so that the wording will capture televisits. In fact, we just released what we call a visit survey. So the CAHPS surveys now are being reworded so that people will understand them as asking about the telehealth visits and telephone visits, as well as in-person visits. And it was very interesting. The number of patients who had made inpatient visits for 25 to 64 was 28%, 65 to 74 was 32%, and 75 older was 33%. So older individuals, at least in the Veterans Administration, were making more in-person visits, and they were also making more telehealth visits. So the next question we were interested in asking, now that I'd had two intuitions wrong, was that I assumed older individuals would need more instruction and have more problems with their care. In fact, when we asked this cohort of about 1,000 people in the Veterans Administration, did they need instruction? 25 to 64, 35% said yes. 65 to 74, 43% said yes. And over 75, 40% said yes. So they were a little more likely to need instructions on how to use the video call or how to do the phone hookup, but actually fairly modest differences, and only fewer than half of the individuals needed any problems. The next question we addressed in this survey was what their experiences with care is. CAPS asked individuals a lot of questions about their care experience, and they rate their care and so on. And interestingly enough, when we asked them to rate access for in-person visits, it was pretty similar across ages. 80%, 86%, 80% had the ratings of access were 80, 86, and 80 across the different age groups, so pretty comparable across the age groups. When we asked them, of those who had made a video or telephone visits, we asked them about access and the ability to get care. And the ratings for the 25 to 64-year-olds was 79. For 65 to 75-year-olds, it was 85. And for those older than 75, it was 86. So although individuals needed a little bit more instruction, their ratings of the in-person visits were comparable across the age groups, and the ratings of video care were actually more positive among the older individuals. So those are just a smattering of results to just give you a sense of the kinds of patterns we're monitoring and trying to understand the impact of. And as I said, I think some of the most interesting work will come as we start to understand what happened for this 8-month, 1-year period when people across the country were just not seeing the doctor as often as we could, as they used to. And Dr. Dong said, what's being done to enhance quality and address gaps? As I mentioned, the area that I do a lot of work in has to do with these surveys. We work with Medicare to field surveys of hospitalized patients across the country. Medicare CAPS is used for probability sample of Medicare Advantage patients and fee-for-service patients across the country. And so we are monitoring very carefully the care experiences of those individuals. And as I said, the surveys are being modified to use wording that captures a broader array of visits. And we have some evidence that makes a difference. Kaiser Permanente just did a very large national study using our new wording, and they do get reports of substantially more visits when you use the more inclusive wording. Vince alluded to a very important issue we all have on our mind about vaccine hesitancy. The new CAP surveys, as I said, will be reworded. CMS Centers for Medicare and Medicaid Services is developing versions of CAPS questions that will allow us to track who is and is not getting vaccines. And there may be some questions about the reasons or barriers to that, but that's in the works right now. So the short answer is older people have been impacted the way everyone in the country is impacted. Probably everyone speaking today and everyone listening has had fewer in-person physician visits, maybe no in-person physician visits. They've probably had more telehealth visits, and that appears to be the case across the age spectrum. Our concerns about particular issues related to older patients because of unfamiliarity or being uncomfortable with technology, whether it's video or phone, so far seemed not to have been borne out. And as care starts to rebound, people start to be making visits. The rebound seems to be most pronounced among older patients. Not a big difference, but they're not lagging other patients. And it may be because those visits are more important or more urgent, but those are the kinds of things we are starting to do. David and I have done studies of trust in healthcare providers and healthcare systems. I've continued to do that work. That's one of the things we're going to try and do more of going forward, to get a sense of what are the origins of vaccine hesitancy, how much of it is vaccine specific, how much is related to discomfort or lack of trust in the healthcare, and so on. We've heard a couple great presentations. I'm sure there's interesting questions, but let me just stop there and turn it back to Dr. Dong to see what questions there are.
Thank you very much, Paul. That was great, all three of our panelists. If I can go back to our supporting team to field questions that we may have for group.
Thank you, Dr. Dong. So I have sent you a question from one of our participants. If anyone has a question, please do not hesitate to put it in the question and answer feature and within your Zoom.
Okay, so we have one question that asks, what do you think may be the long-term effect on older adults because of isolation they face over the last year, and how can family member help with this? Let me turn to the panelists, whoever may want to take a stab at that.
Social isolation, by the way, we've done work, it costs Medicare $6.4 billion now, social isolation. So it's a problem before COVID. It's definitely a problem now. You know, virtual visitations, if they're in a nursing home, but trying to reach out by, you know, Zoom or FaceTime, phone calls, frequent phone calls, definitely have to stay in touch and get your, you know, other relatives and friends to do the same. I think it's severe depression. People don't eat as well, so then you get into physical problems, and sleep becomes a problem too. So it's a very serious problem.
Okay, we have another question. Denise pointed to me that after patients, older adults may have received the second dose, when and how can family safely begin to reconnect with older loved ones that they may not have seen since the pandemic began?
So this is Vince. Vince. I'll take I mean, this is the $20 million question right now. Everybody's trying to ask. There's not a great deal of guidance, and the guidance is probably confusing a public health message from an individual message. And it's very disconcerting. On the public health side, yes, in general, you want to retain some level of social distance, you want to retain mask wearing, and you want to be careful because we don't know, a person who is vaccinated could actually still have be an asymptomatic carrier and transmit to someone else. That's, you know, we don't actually, there's no data on that at all right now from a population perspective. On the other hand, for individuals who've had that second vaccination, waited 8, 9, 10 days, and they're sort of out of that zone, they are, you know, particularly for the Pfizer and the Moderna vaccine, which we've been using here in the States, they are substantially protected in their own lives. How that relates to actually their connectivity, careful connectivity to other people, we are not having a great discussion about that, because on the one hand, it's a clinical question. which is hard to do at the individual level with population data. And so I can only tell you, I've had my second vaccination, and I had a lovely time this weekend hugging my daughter for the first time in many, many, many months.
Thank you, Vince. Maybe this question for Paul. Think about the healthcare delivery and telehealth. Any data suggests that despite individual older adults' positive experience with telehealth appointment, do they feel that they hear, understand, and remember the information with sometimes often degraded signals, either video or audio?
Great question. We don't know, and as I say, we're just starting to collect information. In the Veterans Administration, which is all male and an atypical population, across different types of measures, for example, one of the things CAPS measures is communication. We don't see major problems. It doesn't appear that, at least according from the patient's perspective, that they have a worse experience. For example, in video or phone, we got ratings of coordination and communication. The communication scores for 25 to 64 was 92, for 65 to 74 was 92, and for age 75 or older was 93. Now that doesn't directly answer the question. Anyways, we don't see effects, at least in the kinds of questions we've been asking. The communications experiences, which ask about being heard, provider understanding what you're interested in, and so on. The elders had, not a big difference, but as good or higher a rating. And in fact, the rating was higher than those over 75 who had an in-person visit. I mentioned anecdotally, one of my next door neighbors and close friends is head of infectious diseases at Yale New Haven, and we've talked frequently about how he thinks some of the interactions have been improved because people compile information, they provide information differently, there's less redundancy, there can be more coordination. So we don't know the answer to your question yet, but it doesn't, there's no indication yet that there are problems associated with the video or phone call approach.
Mm-hmm. Thank you, Paul. And related to the Jamie Walker, one of our core faculty member, asked a follow-up question. Say, during the COVID change, CMS is being flexible in terms of telehealth than in the past. And post-COVID, do you think, what will be the drivers that either CMS would either retain this or retract it when they think is no longer necessary, the pros and cons?
Well, here I'm getting into uninformed speculation, but we do have a lot of discussions about this. As I mentioned, talking to a variety of providers, and David probably could comment on this. There's a huge literature emerging on behavioral health treatments via telephone and or video. But a lot of people have identified advantages of telehealth approaches over inpatient visits. So it's easier to set up, you can do it more quickly, you can share certain kinds of information, it's much, much more efficient, and so on. And now we're just learning what visits can we do that on and what visits don't we do it on. But my sense, and this is just pure speculation, is that we will be doing more portal visit, video and telephone interactions than before the pandemic for quite a while, for a variety of good reasons. And we'll know soon, I think, a lot more about the types of visits that do and don't work this way. One of the things we're starting to do is ask very detailed questions about problems with the interactions, the pros and cons of the interactions, what the advantages and disadvantages from the patient and provider perspective were.
Thank you, Paul. Maybe the last question to Susan. I think one of our participants asked about, thinking about older adults gravitate towards, home care, given the concern about the safety and long-term care facilities. Or do you think, what do you think the patterns of older adults getting that social connectedness, getting that people who may be more frail, who may not be able to stay at home, how do they make the choices in terms of the next step of care do you see? What do you hear?
Not sure I'm following the question. People want to be at home in general, and if they have a family member who will help them, they're more likely to be able to do that. It's still expensive to get, paid care, but people still often do, if they don't have a family caregiver and if their needs are pretty high, they just can't live alone. That's the real issue. And then the home, assisted living or nursing home care has been the answer. This whole situation of infections, which by the way occurred before, we had very poor infection control in nursing homes, even hospitals before this. This is really scary to people. And so we are trying to figure out other alternatives other than institutional care. I could spend a lot of time talking about that, what that would be, but I'll give you just one. Homes that like backyards, like a granny home in the backyard of somebody, they call them auxiliary units, has become a popular idea that you don't have to be with a family member. You could actually hire someone to be your caregiver and stay in your home, offering them housing too. There are a lot of kind of creative thinking going on now on how people can stay out of institutions.
Thank you, Susan. We had more questions, but I want to be respectful of our speakers and panel's time. I think, Denise, that will be the end of our session today. Thank you, everyone, so much for joining us, for our panelists, Vince, Susan, and Paul. Denise, any of the lasting words, logistics?
If there's other information you would like, we will send it to you so you can connect directly with the IFH and Dr. Dong. But thank you, everyone, for participating. Please stay safe and please stay healthy.
Thanks to the team. They did a great job. Thank you.
Yes, great panel. Thank you, everyone, for joining us.
And good night, David. Wonderful to see you.
Thank you.
Bye, David.
Good seeing everyone. Thank you for a great session.